So there is some classifications are there. One is something is called simple weaning, which means that the patient who proceed from initiation of the weaning to successful extubation on the first attempt without any difficulty. You assess the patient, you put the patient on SBT, the patient's paused SBT, you extubated the patient not require re-intubation, which means that it's a simple weaning. The second is a difficult weaning, which means that the patient failed initial SBT and require up to 3 SBTs after that initial failed SBT, or as long as 7 days from the first SBT to achieve the successful weaning, which is called difficult weaning. The patient failed first SBT, then patient required at least 3 SBTs or at least required mechanical ventilation after the first SBT for 7 days to achieve a successful weaning. This group of patients comes under difficult weaning. The third group is a prolonged weaning. The patient who failed at least 3 weaning attempts or requires 7 days of weaning after the first SBT. Okay, the patient requiring more than 7 days of mechanical ventilation after the first SBT, or patient requiring more than 3 SBTs, they are all comes under the prolonged weaning. Why we need to classify the patients as simple weaning or difficult weaning or prolonged weaning? Because that outcomes are different. Okay, the first, see here, there is a various studies are showed. In the first one, proportion of the patients with the each group in the simple weaning or difficult weaning and prolonged weaning. Most of the studies, see here, most of the patient comes under simple weaning. The second thing, the re-intubation rate are very high in the patients with prolonged weaning. See here, the prolonged and difficult weaning patients have high rate of re-intubation, and ICU mortality is also very high in the patients with prolonged and the difficult weaning. If you put together all these studies are showed, the most of the patients will comes under simple weaning, but whoever the patients comes under difficult weaning and prolonged weaning patients have higher in re-intubation rate and higher ICU mortality. But not only ICU mortality, the study also showed in hospital mortality also very high in the patients with prolonged weaning, and ICU and ventilator free days are less with prolonged and difficult weaning. So overall, this why we need this classification, because the outcome like re-intubation, ICU mortality, hospital mortality, and the ICU stay or ventilator free days all are worst with the patients comes under difficult weaning and prolonged weaning. This is the one reasons we have to classify the patients as a simple weaning, difficult weaning, and the prolonged weaning. The second is that our goals are also different. If example the patients comes under simple weaning, means you should not have to identify this patient need to be extubated as soon as possible. So this patient need to be identified early and have to start the weaning process as soon as possible. In the difficult weaning group patients, you have to identify why these patients are failing SBT. The reason for difficulties need to be identified as soon as possible and have to extubate the patient. The third group is the goal in the prolonged weaning patient is most of these patients are comes under prolonged mechanical ventilation. There the reason for the prolonged weaning most likely it's a irreversible, or there is a reversible, but it's not going to reverse these problems within a few days. Okay, so like example, the patient is not able to wean because of the ICU occurred weakness, so you cannot treat the ICU occurred weakness, you can only prevent that. So have to wait and watch. So these patients, the prolonged, you can achieve that, decrease the prolonged weaning patients by global management, like as some of the preventive measures, avoid steroids or control the hyperglycemia and achieve a physiotherapy and mobilization, all you have to put together. So there is a why we are classifying the patients simple or difficult or prolonged weaning. One is for the outcome. The second is our goal in this patient is different. Okay. So if the patient in the example, you take it as a simple weaning patient, these patients have to be, most of the patient comes under with the simple weaning group. Maybe the delayed awakening in this group of patients may be due to excessive accumulation of sedation. So that is the reason that most of the guidelines are said you have to stop and see the patient taking spontaneous breath in ICU patients who are on mechanical ventilation. Second, you have to screen the patient. You are not screening, you don't know if the patient is fit for the weaning or not. Okay, you are giving excessive ventilatory assist. It also delays the weaning process. Okay, you have to systematically assess the patients or whoever the patient on mechanical ventilation. Is the patient is ready for the weaning or not? So these are the reasons there is a delay in the weaning process, especially in the simple weaning group. Okay, the main goal in this group of patients is avoid the delayed extubation. Okay, the second one is the difficult weaning groups. There is a reason for the difficult weaning group is that the difficult weaning is incomplete resolution of the illness. If, example, the patient comes with pneumonia with ARDS, the ARDS pneumonia is not improved, then if you extubate, if you put on the patient an SBT, they won't tolerate that. Okay, that is one reason. Prior clinical assessment was wrong. Your subjective assessment, you think that the patient is fit for the weaning, you put on the patient SBT, they didn't tolerate that. Our clinical assessment was wrong. Some of the important coexisting factors, that was a pre-existing factor, or some of the coexisting disease which developed during the stressful SBT conditions. For example, some of the patient will have the underlying CAD with severe LV dysfunction, or some of the patient previously there is known case of CAD. When I put the patient on SBT, because of the SBT is going to increase the work, it's going to stress to the patients, to develop new onset myocardial ischemia during SBT. So the important coexisting factor was missed. New problem arisen in the meantime, that is a new onset LV dysfunction. These are the most common causes of weaning failure in the patients in ICU.